Okay, Assalamu alaikum. It's USML inner circle cardiology part. Starts with the heart block. Okay, before jumping into the heart block, we know that in cardiology there are multiple important topics, and heart block is one of the best. First, first degree heart block, then second degree Mobius type 1, Mobius type 2, and the third degree heart block. First degree is PR prolonged. PR prolonged. Normal PR interval is 3 to 5 in small square. If it is more than 5 small square, it is considered as PR prolonged. PR prolonged and equal. And in first degree heart block, it is asymptomatic. So in first degree heart block, you don't need to do anything, just observe. Then Mobis type 1, usually asymptomatic, a progressive prolongation of the PR interval followed by a drop bit, progressive PR lengthening followed by a drop QRS complex. Observation, rarely ppm permanent pacemaker placement is needed. Mobis type 2, fatigue, lightheadedness, syncope, fatigue, lightheadedness, syncope. In Mobis type 2, there is constant PR interval with a randomly dropped QRS complex. Constant PR interval with randomly dropped QRS something. ppm placement should be done, permanent pacemaker placement. And the third degree heart block, like complete dissociation of P wave and QRS complex. Complete dissociation between wave and QRS complex. In here, atrial rate is more than the ventricular rate, and in third degree AV block permanent pacemaker is the treatment. Okay, this is junctional rhythm. Okay, we know the heart rate calculation: 300, 150, 100, 75, 60, then it is near about 50. So our junctional rhythm rate is 40 to 60 beats per minute. Uh, Rate is 40 to 60 beats per minute, and regular rhythm is regular. Look at the RR interval. Rhythm is regular with narrow QRS complex. QRX narrow, and no normal P wave. No normal P wave preceding QRS complex. No normal Q wave preceding QRS complex, and retrograde P wave may be visible to QRS complex. This is retrograde P wave may be visible to QRS complex. Junctional rhythm. In junctional rhythm, usually SA node dysfunction or AV block. Usually SA node dysfunction or AV block. Usually SA node dysfunction and AV block. An impulse initiated by AV node or bundle of his after timely conduction not received from the above due to retrograde depolarization of the atria starting from the AV junction. Now, first degree AB block. First degree AB block. We know that the first degree AB block PR is prolonged and equal constant PR prolongation uh, with P wave and QRS complex. PR prolonged more than zero point 0.2 second one large box, or 3 to 5 small square, 3 to 5 small box, and regular rhythm with constant RR interval. What is the recommended management for a patient with first degree AB block with QRS complex? With a normal QRS complex less than 120 millisecond, observation should be done. Likely due to AV node conduction. Likely due to AV node conduction. Prolonged QRS indicates a delay AV node and warrants electrophysiological study. Electrophysiological study. Now second degree AV block, Mobis type 1, Mobis type 2. Mobis type 1 usually AV node, and Mobis type 2 is below the AV node, and a bundle of his. So Mobis type 1 is usually AV node, and Mobis type 2 below the AV node, bundle of his. ECG finding in Mobis type 1, progressive prolongation of the PR interval to a non-contacted P, group beating, and Mobis type 2 is PR interval remains constant with intermittent non-conducted P wave. PR interval remains constant with intermittent non-conducted P wave. QRS complex Mobis type 1 is narrow and Mobis type 2 is narrow or wide. Exercise or atropine, usually type 1 improves exercise or atropine is improved by type 1 Mobis, and it is worsens type 2 AB block. So exercise and atropine worsens type 2 AB block, but vagal maneuver paradoxically improves type 2 AB block, but it worsens type 1 AB block. Risk of complete heart block is type 2. It has high risk, but the type 1 has low risk. Okay, now Mobis type 1 is a prolonged, then let's drop it. Disrupted conduction usually within the AV node, disruption conduct within the AV node. Constant include enhanced vital signs, constant include enhanced vagal tone, pharmacological AV node blockade, ischemia, age-related conduction dysfunction, and features we know. Complete heart block. What is the management of the stable patient with dizziness, weakened, and ECG findings abnormal? Complete heart block should be managed within temporary pacemaker. Management to temporary pacemaker underlying evaluation for identify the reversible cause. Unstable angina should be given in atropine. A permanent pacemaker is not indicated if no reliable heart block found on further evaluation. This is the third degree AV block. Between P and Q complex, there is no relationship. There is progressive prolongation of the PR interval, then a drop beat is present. EKG findings, there is complete failure of the impulses to capture the ventricle. There is ventricular rate is always lower than the atrial rate. So atrial rate is higher than the ventricular rate. The P wave does not have not relation to QRS complex. Sudden onset systole, asystole, which may lead to sudden onset asystole, which may lead to stroke syndrome, sudden loss of consciousness, sick sinus syndrome, elderly bradycardia, fatigue, dyspnea, and bradycardia syndrome, arrhythmia, palpitation. ECG finding sinus bradycardia, sinus pause, delayed P wave, and synotrial exit block. There may be a dropped P wave. So pacemaker is the treatment of choice, with or without rate control if tachyarrhythmia is present. So that is all about uh, heart block, first degree, second degree, and third degree, along with 6 sinus symptom. Hope you enjoyed.